Good morning, everyone. It is April 8th. I think one day we're going to do all deep breaths together. That'd be a really nice way to start this, but not today. I was thinking it more because I think it's going to be in the 90s this weekend. So what an interesting weekend it will be. And I was looking at Rehan's slides and I see what looks to me like a little sun. So that's why I thought of that. Anyway, we have one of our wonderful PGY 5 second year ID fellows presenting. And I think it's the first time he's presenting to our high rounds audience. So get ready for those who haven't heard him speak yet. Always very invigorating and thoughtful discussions. And we're going to be taking a little bit of a turn from HIV, although very relevant to our patients. So let me introduce Dr. Rehan Syed, who completed his undergraduate degree at Stanford in human biology. In 2011, he received his MSc in public health at the London School of Hygiene and Tropical Medicine. He returned to California in 2013 and completed both medical school and residency in internal medicine at UCSD, where he is now pursuing his infectious diseases fellowship. In fellowship, he has worked so far in the Catanzaro-Rodwell lab, investigating the progression of tuberculosis from exposure to active disease, as well as novel methods for the rapid identification of drug-resistant Mycobacterium TB using molecular techniques. Also, a couple of other fun facts that I know about Rehan. He was selected in 2021 by the graduating internal medicine class for top fellow educator, if I said that right. He also went to Cornell undergrad and is from the Ithaca area. No, that's not true. From Ithaca.
Right. Born in upstate New York.
Born and bred in upstate New York, Ithaca. So we always talk about that when we talk about college town bagels and all the other good things. And finally, Dr. Syed got engaged like the day after he came off a really long service with me, or close to that. So it was very fun and a rewarding end. Anyway, so those are just my random facts that I had. Rehan, I'll turn it over to you. If I'll keep an eye on the box. I know you're pretty good about that too. I will stop you for questions that arise. We'll try to save some dialogue for the end.
Okay, sounds good. And because of my setup, I don't have the chat open. So yeah,
it's on me. Don't worry about it.
Yeah. So, well, it's very nice to meet everyone. This is the first time I've presented, I think, to this group, I'm pretty sure. And some of you may know me, but for those who haven't, I hope we meet in person sometime, just so we can get to know each other better. Today, I wanted to talk about a relatively broad topic, but there is a sort of ultimate purpose to this, I promise. And I think it's very relevant to the audience who is here today. So I just want to start off by saying that there are no disclosures related to this talk. Luckily, I guess I don't have disclosures. Some might say that's something I should strive for. Regarding the sort of the course of today's discussion, I just want to give an overview because we will be moving around a little bit. And part of that is related to the fact that there's this new article that came out just at the end of last month, a few weeks ago, that I want to spend a little bit of time discussing, but it really helps to know sort of the history of the disease, of cryptococcal meningitis, the epidemiology and the impact. And so I want to kind of walk us through those areas first to lead up to the ultimate, impact and conclusion. I'll also spend a little bit of time on the clinical management of cryptococcal meningitis. I know the audience that I'm speaking to is quite expert, and so I don't want to appear to be oversimplifying anything, but if just for the sake of time and the scope of this presentation, I apologize if it seems like some of this is too surface level. So I just want to get that out of the way ahead of time, but I think this will be interesting for everyone. So with that, let's get started. Let's just start with sort of the background. What is Cryptococcus? Where did we get our information about it? And sort of what sets the baseline for us to think about this disease. So I'll start with the organism. Cryptococcus neoformans was the first identified species. And it was identified in the late 1800s by Otto Busse, sorry if I'm messing up his name, well in Germany as a assistant to a pathologist, and then became a well-known pathologist in his own right. And so he isolated this specimen from the tibia of a young woman with periosteitis, and then a dermatologist later isolated the same fungus from the same patient. And so initially, cryptococcosis was named after these two individuals. Now, it had a couple of different names. Saccharomyces hominis was its first name. Saccharomyces neoformans was given to it by another individual who isolated from peach. But ultimately, in 1950, it was settled upon that it should be called Cryptococcus neoformans based on differences in morphology from Saccharomyces. And broadly speaking, there are two species of relevance, C. neoformans and C. gaddii, which I think many may be aware of. There are 4 serotypes. And so you may see this as well as genetic or molecular markers in some of the papers. The big thing to remember broadly is A and D are C. neoformans with 2 varieties, and B and C are gaddii. Now, it's a little complicated because there also are hybrids. There are also other species that have been isolated in immunocompromised individuals, but it's not clear whether they are pathogenic or not. What are they? Well, you can see a SEM picture on the left. These are oval encapsulated yeasts. They are asexual unicellular organisms that reproduce via multilateral budding. Something that I found interesting while sort of prepping for this was there actually is sexual reproduction that's been noted through these 2 mating types, MAT alpha and MAT A, but these are observed in laboratory conditions only. It's more of a trivia piece than anything. But the really important part is that there are these large polysaccharide capsules, which I think we've all seen in the pictures of with India ink and so forth. And the predominant polysaccharide is GXM, and this antigen is what our crags are detecting. C. neoformans is found worldwide. It's in the soil. There is an association with bird droppings, such as pigeons, and as well as other birds. But interestingly enough, it really does seem like it's the droppings, whereas the animals themselves may not have as much organism when they've tried to isolate, for example, from the beak, from different parts of the body. So that's one thing to keep in mind. Pigeons will sort of be one of those recurring themes that is brought up if you talk about this and look at articles. Rotting vegetation such as trees and also dairy in terms of some certain outbreaks of cattle have been associated with C. neoformans. Now, gaddii is traditionally more associated with subtropic and subtropical areas. And so, we're going to be talking about sub-Saharan Africa, Australia, but relevant to us, and I think most may be aware of this, but we have eucalyptus here in the west coast, especially the southwest. So in San Diego, we have C. gaddii associated with eucalyptus. Many other trees are also associated with C. gaddii. For example, in the Mediterranean basin, there's less eucalyptus, but there are other trees. So it depends kind of where you're looking. And it's been isolated from the soil, but it's less traditionally, associated with soil alone. Now, on the left is an image of sort of the global distribution and the breakdown. Overly simplified probably is VN would be the neoformans and VG is gaddii. Now, again, it's a little more complicated than that, but the way I would look at this is that if you are interested, you can go and look at some of these studies and you can see that there is quite a different breakdown depending on where you're looking internationally. So that's important to know if you're treating patients. Now in the US, for those who are seeing patients, there are a couple different ways that this has been looked at. Definitely we think of the West Coast as generally having C. gaddii more so than anywhere else, but the Pacific Northwest, especially in Canada, there have been outbreaks in the past. And so those are areas that I would be more mindful of this species. Now, we know C. gaddii is more likely to cause disease in immunocompetent hosts, and C. neoformans has a predilection for immunocompromised hosts, but you can see both in both parties and both hosts. There is a slight tendency towards cryptococcomas, more so in gaddii than neoformans, but again, both can present these ways. I think we're all aware that with the HIV/AIDS epidemic, that there's been a major issue with C. neoformans becoming a worldwide problem. But it's also important to recognize there are other diseases that can cause an individual to be susceptible: steroids, organ transplants, malignancies, certain medications like ibrutinib. So it does vary depending on the host, and we'll talk a little bit about that in just a little bit. And I don't want to spend too much time on the virulence factors, but I think some of these are, again, kind of helpful to know in terms of how this bug works. It grows at 37 degrees Celsius, which is the human body temperature, which is why these two species are pathogenic to humans as opposed to some of the others. Again, there's this polysaccharide capsule, which has a ton of different functions. And so, I won't go through all of this, but just know that it helps with the evasion of the host defenses. And then there are a couple other virulence factors, lactase, PLB1, urease, and then superoxide dismutase. And these are all there to help evade the host, disseminate, and really with blood-brain barrier crossing through phagocytosis. So it's called a Trojan horse mechanism, and we'll kind of just maybe walk through that very quickly. Inhalation of the spores or the cryptococci themselves from the environment is the way of inoculation. It goes into the lungs. It survives in the relatively neutral or basic lungs using some protective enzymes like GCS. Ultimately, its goal is to be phagocytosed and parasitize these macrophages, which are then circulated in the bloodstream, can get multiple places all over, but oftentimes where we see disease is going to be a CNS disease, and this is through crossing of the blood-brain barrier within these macrophages. The yeast cells and spore forms are almost always inhaled. That's the traditional way of transmission. Direct inoculation of the skin is possible, but very rare. And one thing that is kind of interesting is we are seeing transplanted tissue in solid organ transplant causing what you could call human-to-human transmission, but it's not traditionally human-to-human transmissible disease. And again, I think as probably most of the audience is aware, there's certainly CNS disease is what we commonly see, but you can also have pulmonary disease, extrapulmonary, extra-CNS disease, and then asymptomatic angiogenemia. So let me just quickly go through some of these. Again, this is very much a sort of broad overview level of these things, but we'll dig into some of these just a little bit later. The CNS disease is the most common presentation. Some people will call CNS disease meningioencephalitis almost on principle rather than meningitis because there is almost always a parenchymal involvement. But again, I think both are oftentimes used interchangeably, and localized granuloma formation, cryptococcomas are certainly possible, and we see them. CNS disease, we'll talk a little bit about this again in a little bit, but usually it's an indolent onset. Things like photophobia, neck stiffness are actually the minority of patients. And then, the impact worldwide is quite significant. And I want to talk about that specifically a little more because it will be relevant when we get to some of the new studies that are coming out. Pulmonary disease, it's a little different, wide range of presentations from asymptomatic disease to ARDS. And it really does kind of run the gamut. Immunocompromised hosts tend to have symptoms more often, but immunocompetent hosts, almost 30% to half of them may have no symptoms. And the other thing too that I think is kind of important to know is that for immunocompetent hosts, there's one study at least showing that 32% achieved spontaneous resolution without antifungal therapy, but oftentimes individuals who are symptomatic, and certainly if they're immunocompromised, we will end up treating with either fluconazole, itraconazole, or more severe other regimens as well. But the focus of today is not pulmonary disease. So I'll kind of be brief on that. Same with non-pulmonary, non-CNS disease. This is disseminated disease. So, you can see skin and bone involvement like the individual from which C. neoformans was first isolated, as I mentioned. But really almost any site can be involved. I thought it was pretty interesting with solid organ transplant recipients. Almost within the first week, if there was going to be a infection, it would be detected. And it was usually in the allograft or the surgical fossa. So that was thought to be donor derived. So it's just something that was kind of interesting because I never thought of Cryptococcus as a transmissible infection, but it makes sense. So let's shift gears a little bit more towards the epidemiology, sort of the burden of disease, because this is really where the impact of some of the new studies are going to be felt. So, it's really important to recognize this is a worldwide problem. This is something we definitely treat in our patients here in San Diego, but the scale is quite enormous. There was a really nice article from 2017 by Rajasingam et al. This paper shows up everywhere once you start recognizing it, and I'm sure many in the audience may be aware of this. But it was nice because it tried to look at the global burden of disease based on 2014 data, specifically of HIV-associated cryptococcal meningitis. And so they looked at the joint UN program on HIV and AIDS estimates to try to figure out what is the prevalence of HIV, what are the CD4 counts. They looked at multinational cohort studies, and then they looked at cryptococcal antigenemia studies, and they tried to take all these studies and integrate it into one data set. And from this, they created a model to estimate the annual incidence of cryptococcal meningitis, as well as the mortality. And I don't expect anyone to read this slide because it has a lot going on, but this is just an example of all of these different cohort studies in different countries and looking at the different estimates of the cryptococcal antigen prevalence. And they took this sort of information and they created these charts showing, okay, how many adults are living with HIV? How many, what are the CD4 counts on average in these different locations? Who's have virological failure? Who's had, what's the CRAG prevalence? And they use all of these numbers as well as uncertainty intervals to create that model I was talking about. And so this is the annual incidence of cryptococcal infection by country that they came up with based on the 2014 data. And so you can see very visually that sub-Saharan Africa certainly has a high annual incidence, but really multiple areas, Brazil, Russia, South Asia, Southeast Asia, all of these places have pretty high comparative incidences of cryptococcal meningitis. And the way that they display the information, I think, is really nice, but it can be a lot of numbers just to look at. So I just want to walk us through a little bit of sort of the main findings. Globally, they found that there was 278,000 total cryptococcal antigen positive patients, and 223,000 estimated with cryptococcal meningitis. But the nice thing that they did too is that they looked at, okay, what's the incidence of cryptococcal meningitis in these high prevalence areas? Who are the number at risk? What's the cost of screening? And then sort of the HIV budget associated with it. So the nice thing is they also looked at the impact and the practicality of tackling this problem, just to show, more than anything, the scale of the issue and what needs to be done. So not only did they estimate information, they sort of went the next step and said, okay, what is the impact? What's the cost impact of this? I thought that was really helpful. Probably easier to digest for many people would be a graph, which I'm showing here. You can see that the burden of disease in sub-Saharan Africa certainly is the largest, and I think for probably clear reasons. Asia and South and Pacific, especially in South Asia and Southeast Asia, and then of course worldwide we have this issue. And one thing that they emphasize is that the 20 to 25% of those presented to care have CD4 counts, CD4 cell counts less than 100, and so the people who are coming in, understandably, are pretty sick. And this is a very large number. So the scale of the problem worldwide is, I would say, enormous. And it's even more significant when we look at the mortality associated with this problem. So we know what the incidence is, we know the impact, but what's what is the morbidity and mortality? And around 15 to 20% of all HIV-related deaths are due to cryptococcal meningitis worldwide. And really, this is related to different treatment regimens. And so this ranges from 20%, 30%, all the way up to 96%, depending on which regimens different countries have used. And you'll see this 10 to 12 week mark of a lot of studies used as a mortality sort of endpoint. And so that will be relevant when I talk about an article in just a little bit, because the 10-week endpoint is, again, what people are really, really focused on. I won't go through the entire way that they did this literature review, but they ended up with 25 publications that they used to inform their mortality report. And I thought it was just interesting because, we may recognize one name, Dr. Shai, as one of the articles that they used. So I thought that was just kind of fun. There's a lot to go through here, and I don't want to go through all the numbers, but if anyone's interested in this paper, it is interesting because it breaks down, for example, here for HIV-associated cryptococcal meningitis, the 3-month endpoints, the 6-month endpoints, the 1-year endpoints, and the studies within those groups with the estimated mortality. So they really got a good sense of what different groups were reporting as mortality rates. And these numbers are quite high, I will say. Highly variable, but very high in general. And then they also looked at it for non-HIV associated cryptococcal meningitis. And then they tried to look at protective factors, risk factors, and then factors that had contradictory results. So this is pretty interesting, I think, if you want a good summary. This came out in 2018 by Pasquare et al. So just something to consider looking into. And they did this for non-HIV associated cryptococcal meningitis as well. This is where I think the money is, for me at least, is that they really well visualize the one-year mortality from these different studies with different regimens, because this is part of what's separating these groups out. There are many factors in terms of outcomes, but the regimens have been quite different in different countries due to availability, due to standard of care, and there have been changes. And so we're going to talk about that. But there's always been a push for oral medications as opposed to injectable. So fluconazole or fluconazole and flucytosine, those have always been, there's been interest in those. But we always see the mortality for example, fluconazole alone to be really high. You can see here 80%. Whereas those with amphotericin B and fluconazole or amphotericin B and flucytosine, which is what we use here, those mortalities are a lot lower, 40% in some of these reviews and cohorts. So it really depends. It's really important to look at the different treatment regimens because the difference in outcomes is large, and even small differences in treatment outcomes are really impactful when we're talking about this scope of a problem worldwide. I'm going to take a slight detour just to talk about the clinical management of HIV-associated cryptococcal meningitis. I know that a lot of people on the call today do care for these patients, so I don't want to come across as being too superficial. At the same time, this may be repetitive for some individuals, so I'll try to strike a balance there. But just for completeness, I want to make sure that we understand what's going on in terms of our management here in the US, as well as then we'll talk about sort of the worldwide WHO recommendations. So we have a point of reference. And then we'll talk about the more recent updates so that we can inform whether worldwide regimens are changing as a result, or whether we might even have changes here in the US as a result. So let's review that. Again, cryptococcal meningitis is usually a subacute onset. Median onset's around 2 weeks following infection. There can be more rapid onsets, depends as well as in terms of if virus is playing a part in that. Fever, headaches, fatigues are the most common symptoms, and only a minority, up to a third, will have the classic meningitis symptoms of photophobia, neck stiffness, etc. But you do see high levels of altermentation, memory loss, lethargy in individuals who have an elevated ICP. So those individuals may just present as really confused or even obtunded, and so that's something to look out for and have high index of suspicion. Diagnostically, I think we're all familiar with the cryptococcal antigen test, the CRAG. But what is interesting and should be recognized is that there really is a survival difference between different titers, and this is basically a reflection of level of disease. And so there are different CRAG tests, and I'll outline the three in just a second. But the LFA is commonly used, and so a titer of greater than 1 to 160 is associated with high risk of disseminated disease, and you can see on the right side, it's split into low titer, medium titer, and high titer. And so really above 1 to 160, you should worry about disseminated disease, and greater than 1 to 640, you should presume that this is a CNS disease. Interestingly enough, early disease may have positive serum CRAG and a negative CSF CRAG, so that's worth keeping in mind. And then oftentimes with HIV-associated cryptococcal meningitis, about half patients will have positive blood cultures, which I didn't truly, I think, respect that it was that high before reading into it a little more. Now, CSF, of course, is the way we really sort of have to focus on diagnosing these patients. In terms of the cell counts, et cetera, protein is usually high. Glucose can be normal or a little low. You can have lymphocyte phagocytosis, but really the big things to be looking for are CRAGs, and then also looking at the opening pressure. So 70% or so of patients will have a high opening pressure. That's more than 25 centimeters of water. And the goal is less than 20. And so that's one thing definitely to be mindful of. It's absolutely important to get a lumbar puncture in these individuals. And then for the CRAG, there are, again, a couple different products out there: LFA, EIA, latex agglutination. In general, just know what product your institution is using, because there are differences in the titers. So for example, LFA titers tend to be around 4 times what the EIA or latex agglutination titers are. So just have a reference for your institution in terms of how to interpret. India ink and gram stain, if there's a high burden of disease, you definitely can pick up the organism. The problem with India ink really comes out when you have a low organism burden. But so really crag and culture are the two most important, but I still personally, sometimes send an Indian ink as well, depending on the situation. One area of contention that had come up when I've been treating patients, at least, is biofire has been a new thing. And for a while, it seemed like almost like crags weren't being sent from the ED automatically. I think there's a little bit of reliance on the biofire, which is a PCR method. And it's a good method if there's a moderate to high burden of disease. It's just when there's a low burden of disease of organism, your sensitivity drops significantly. So, it's one of those things that you can use to add to your regimen, but I would still send a crag, certainly. Now, the thing also that I thought was kind of interesting is I've always been under the impression that your Cryptococcus organism does not produce 1,3-beta-D-glucan or Fungitel. But in cryptococcal meningitis, it does produce enough usually to have a decent sensitivity and specificity. Again, not that I would diagnose based on this, but almost a 90% sensitivity and 80% specificity, sensitivity, depending on CSF or serum. So that is something I don't usually send with individuals with cryptococcal meningitis, but again, it's something that just to be mindful of. Let's talk about the treatment and the standard of care in the US. I don't want to, again, go over things people are very familiar with, but clinicalinfo.hiv.gov has these regimens that are very well laid out. We do 2 weeks of liposomal amphotericin B plus flucytosine, and this is our induction therapy. The flucytosine needs to be adjusted for renal impairment. You need to do the normal things like hydrating the individual with amphotericin, checking electrolytes, close monitoring. Interestingly, there are multiple articles coming out with trying to change and simplify regimens. And so based on some of these studies, they do make mention of the fact that a typical duration of induction is 2 weeks, but in the setting of toxicity, there are studies out there that show that 1 week of amphotericin B deoxycholate was not inferior to 2 weeks. And so this is actually part of that summary that I kind of showed earlier. So there is recognition of this, but again, it's not something I think most people would jump to. There's a consolidation therapy, which is pretty, again, standard. It depends on the individual exactly how this will go, but usually when you have a negative CSF cultures, you will continue on someone on fluconazole 800 milligrams and then drop maybe to 400 potentially, do this for at least 8 weeks, and then ultimately switch them to maintenance therapy, which is a lower dose of 200 milligrams. And that will be continued until you basically there is at least 1 year of therapy. So the individual is asymptomatic, the CD4 counts improve, and at that point you can discuss stopping maintenance therapy. The treatment for non-CNS, non-pulmonary disease is pretty much the same as CNS disease because it's disseminated. So there are further guidelines here, and you can always look these up at the clinicalinfo.hiv.gov. These are the summaries I'm showing, but there's all the details in terms of where the data comes from there as well. And so I think that's a resource I think, again, many in the audience are intimately familiar with. So I won't belabor that. Elevated intracranial pressure, it's important that this be checked, especially in the lateral decubitus position. This is not always done, initially, especially, and I know LPs are always sometimes hard to get. So this is really important because there's a survival benefit to lumbar puncture. And there are complications associated, especially with this opening pressure of greater than 25 centimeters at cutoff. And the goal is to really lower it below 20 centimeters. Some individuals may require shunting if repeat LPs are not tolerated or not possible. And then the other thing to know is that really medications are not effective at lowering intracranial pressure. It is really a mechanical intervention that's needed. So I just want to emphasize that doing lumbar punctures and making sure you're treating the elevated intracranial pressure is really important for these individuals. And when we talk about most of the studies that are done abroad, like in sub-Saharan Africa, there are differences in access to lumbar punctures, but in general, the goal is to do repeat lumbar punctures in all their patients as sort of adjunct to whatever therapies are being used because it's considered standard of care. Iris, we see this in individuals, certainly, especially cryptococcal meningitis. And so the only thing I kind of wanted to emphasize here that, again, I was not aware of, but many may already be aware of, is that the biofire has been described as being a good test for, well, one of the tests you should use to determine paradoxical iris versus relapse. Usually I think of, CSF cultures and the clearance and that status, but it does seem like the biofire, if it's positive, can help indicate relapse, and if it's negative, leaning more towards iris. So I would just add that as part of one of your portfolio of options if you're interested, if you're trying to figure this part out. Prevention, I think we all know, antiretroviral therapy is important, routine surveillance. In the US, antifungal prophylaxis is not routinely recommended, but internationally, where there's a high incidence disease and they cannot do CRAD screening routinely, for those with a CD4 of less than 100, they do recommend fluconazole prophylaxis. But again, we don't do that here routinely. Okay, so I think that really establishes a background of the disease, the organism, the disease, and sort of the global scale of the issue, as well as what we do here in the US routinely. But I want to focus a little bit about the changes that have been going on internationally in terms of the regimens, which are not the same as what we tend to use here, and some of the new findings that I think will cause a shift in that again. And so really the big time point until just now to look at is 2018. Because before 2018, the WHO first line recommendations were induction with IV amphotericin B, this is the conventional deoxycholate, and then flucytosine for 14 days. Now, this is a really challenging regimen because amphotericin B deoxycholate is not an easy medication to give. It's not, you have to monitor patients very closely, and flucytosine has limited availability worldwide. So it's really spotty in terms of access. So IV amphotericin B and fluconazole is used as an alternative, and it seems to be effective as well. But this is not an ideal regimen especially in resource limited settings with high incidence. It's a big burden on the health system. And I think this is an area that people have been continually trying to improve. Consolidation and maintenance, relatively similar to what we do here. There are some some caveats where testing is not available. But the big change happened in 2018 because this is when the ACTA trial came out. And a lot of these trials, when you look at them, they each build upon the previous trials. So people try out a certain regimen, it may or may not work, and then there's a modification to it to see if this new change worked or didn't. And the ACTA trial is kind of nice because it compared these 5 different arms, and it was an open label, randomized controlled trial, 700 participants, sub-Saharan Africa. And they looked at this 10-week mortality. And the different arms that they looked at were amphotericin B and flucytosine, either 1 or 2 week regimens, amphotericin B and fluconazole, again, 1 or 2 week regimens, or a 2-week fluconazole flucytosine regimen. And the goal there is to get an oral only regimen. Ultimately, the conclusion from that study was that the 1-week amphotericin B and flucytosine regimen was non-inferior to the standard of care at that time. And there was some concern that the 2-week fluconazole and flucytosine didn't quite meet the parameters that they wanted in terms of outcomes. So ultimately, there was a big change. And the induction therapy now, this is the standard worldwide, and it's what's been going on for a number of years now, is that you do amphotericin B deoxycholate plus flucytosine for 7 days, and then do high dose fluconazole for another 7 days to complete induction. And then you transition to maintenance sort of, per usual. And this is another way of showing the same information. You have week 1, this is when the hospital has the patient inpatient for the amphotericin B. And then week 2 tends to be, depending on how sick someone is, they may be discharged or kept in the hospital. And then week 3 and onward, usually is outpatient. And so after all of that, I think we finally reach kind of the area that I want to spend a little bit of time talking about, which is this new trial. So the Jarvis et al. Group, this is a group that is really sort of spread out in worldwide, but this study was based out of the London School of Hygiene and Tropical Medicine. The article came out on March 24th, so just again, a couple weeks ago. And it was really kind of nice because what it did is it took the ACTA trial and it looked at, hey, look at this fluconazole flucytosine regimen. It's not quite where we want it to be, but can we do something to bring it to the point where we want it to be? And so their idea was to do this single dose liposomal amphotericin B treatment and see if adding a single dose to that regimen improve its outcomes enough to make it a viable alternative. They ended up recruiting 844 participants in 5 different countries. It was an open label trial, and they tried to look at 10-week mortality, and they powered it as a non-inferiority trial. So they're not trying to say that this is way better than what we had before, but is this not worse? Is this equivalent? but an easier regimen to administer. That was kind of the goal of this. So I know this is pretty small, but they took 844 patients and they randomized them 1-to-1 to 2 arms. And I think really the bottom right here is what I want to show is there's this experimental intervention arm, and then there's the control regimen. The control regimen is the WHO standard of care at that time. This is based on the 2018 ACTIC trial. And this is 7 days of amphotericin B deoxycholate and flucytosine followed by the high-dose fluconazole. So again, standard of care. And then experimental regimen is a single dose of a single high-dose 10 milligrams per kilogram liposomal amphotericin B, not deoxycholate, followed by 14 days of oral flucytosine and oral fluconazole. And again, that's a high dose of oral fluconazole. And they looked at these two groups. The way that they split them, it was actually quite nice. It's pretty even. There were some people who were excluded from the intention to treat analysis because they either didn't have cryptococcal meningitis ultimately, they were HIV negative, and this was looking at HIV-associated cryptococcal meningitis, or they met late exclusion criteria. The late exclusion criteria is just a set of criteria. Because some of these patients are so sick in the ICU, they want to recruit as many people as possible, including really sick patients. And it's really hard to recruit ICU, bedbound, not able to give any kind of consent patients, even though those are really important in terms of outcomes. And so the late exclusion criteria were certain ways that they could recruit these individuals. And then ultimately, if they didn't meet all the criteria, based on the rapid enrollment, then they would be excluded later on. So that's why 12 in both arms were dropped. But again, the numbers are still very high. 407 were included in both the intention to treat analysis arms of both arms. And then a couple were excluded because basically they didn't quite meet the per protocol. And so there's just below 400 in each arm. The really cool thing about this study is that no one was lost to follow-up at all. So everyone remained in the study that was recruited. And I think that's pretty extraordinary. And I think there are two parts to that. One, the study is really well run. Two, these are sick patients. And so a lot of them are in the hospital system. But again, there's the outpatient follow-up that people are looking at. This is a 10-week out, people are not in the hospital for 10 weeks. And so it's just really extraordinary, I think. And this is it's not something you see commonly. So kudos to them. I want to talk a little bit about the baseline characters so we get a sense of who these patients are. I've highlighted the intervention group, but just, you can look here, but really the control group is quite similar to the intervention group. So I don't think there's major differences between the groups from, at least from my perspective. But almost a third of these individuals have a new diagnosis of HIV on presentation. Many had, certainly almost, I would say almost 100%, but yeah, 96% had headaches, which again is understandable. But just for, in terms of severity, 10% had seizures within the past 3 days. Almost 30% had a GCS of less than 15, and 40% had elevated opening pressures. And the CD4 counts are in the 9 to 56 as the intracortical range. So these are, very, I think, ill individuals who are presenting, quite progressed in some of their disease. And so this is not unexpected, but just gives a sense of the population we're talking about. It's really important to look at the outcomes with them, being mindful of what this patient looks like in front of you. These are really sick individuals. And so whatever outcome we're looking at in 10 weeks, we wanted to apply to people who are both sort of walking in and it's been sort of an indolent thing versus people who are really sick in the ICU. So again, this group really sort of included a lot of different people from different levels of disease and different symptoms. And this is where the real outcome, the primary outcome, primary endpoint is shown. And they showed it as both the intention to treat population, they show it per protocol population. I will just say that they're very similar, so you don't need to, I think, overly focus on that. The mortality at 10 weeks was still pretty high, 25% in the liposomal amphotericin B group. But that's, unfortunately, that is kind of where we expect with optimal care at this point, unfortunately, versus the control at 28%. And so compared to the standard of care, we certainly see that it's not inferior. And they did an adjustment as well. And if you look at the adjusted analysis, there's almost a suggestion towards improvement with the liposomal amphotericin B, but that's a little bit, I think, some might say that's too much to call. But it looks like the intervention is certainly not, from a mortality standpoint, worse than the standard of care at that point, which was 7 days of deoxycholate. So the other thing they looked at too, which I'm putting a little bit less emphasis of, but I think is nice because it's sort of the mechanistic part of this, is that they also looked at early fungicidal activity, and they used a couple of different modeling techniques, but they looked at the difference between these two regimens and to see if they're actually killing this organism. And really, there's no difference. So they're both effective in terms of early killing of the pathogen. This is another way of showing some of the same information. So you can see the all-cause mortality at week 10, but you can see the two arms, the control and the intervention arm, really don't have much separation. There's even a slight trend towards, and who knows at week 20, 1 year, what the difference might be. But in liposomal after there's almost a trend towards improved outcomes. And you can see that on the right side at the forest plot, where we look at the intention to treat population with the adjusted analysis, which is basically just taking into account patient characteristics like age, sex, GCS, those sorts of things. And so they're trying to adjust and control just for the regimen rather than the illness of the patient, and other comorbidities. And you again see this trend towards improvement with the single dose liposomal amphotericin B treatment. And so it's, I would say at this point, we can say, hey, this single dose new regimen is certainly not worse than our current regimen, but is it better? And this is where I think the argument for why it's better comes in, and that's the adverse effects. So we know that the number of adverse effects from liposomal amphotericin B treatment, as well as flucytosine, some of these can be quite significant. Grade 3 and grade 4 adverse effects are oftentimes looked at. Grade 3 is really serious, requiring hospitalization or close monitoring. Grade 4 is life-threatening. So, we're talking about severe, clinically relevant adverse effects from these treatments. In the control arm, around 62% had grade 3 or grade 4 adverse effects. In the intervention, it was about 10% lower. But I think that's really relevant too, because if you look at grade 4, this is life-threatening. There's almost a 10% lower chance of having an adverse effect. And again, these are all significant at the 0.05 p-value. They also looked at the number of patients with anemia. Basically, fewer than half of the patients had severe anemia, grade 3, grade 4. Fewer than half, almost a third almost of patients, two-thirds less received blood transfusions as a result. And there was a much lower increase in creatinine level, which makes sense because they're getting a lot less amphotericin B, and it's liposomal amphotericin B as opposed to deoxycholate. So there are lots of different ways to look at this, but I would say that almost across everything, you're seeing either the same or an improved adverse effect profile, and significantly so. Again, remember the scale of the issue we're dealing with, the number of individuals who aren't going to undergo treatment, worldwide. So these are significant differences. So this is another way just to sort of visualize it. For me, the death at 10 weeks is non-inferior. So it's certainly as good, if not better. And the adverse effects are far fewer, almost 10% fewer. And that is really significant at the population level. The other thing that, that I think everyone is paying attention to as well is that the physical burden or the monetary burden, the practical burden on healthcare systems in administering a single dose of IV liposomal amphotericin B is much less than having to do repeat infusions for weeks of deoxycholate, and then the close monitoring that's associated with that as well. So the burden on the healthcare system is significantly diminished. There are some caveats to that. One is that liposomal amphotericin B is certainly not available to the same extent that deoxycholate is. So that's one thing that, it's only a single dose only, but that's still quite significant in log settings. So that needs to be addressed. The second is that there is presumably a benefit to a single dose of IV medication in the sense that individuals could be followed up as an outpatient much earlier. Now, for this study, in both arms, they were in the hospital for at least 7 days, longer for many. But if individuals are getting a single dose of IV amphotericin B, if they don't need repeat lumbar punctures or reasons to stay in the hospital, they're going to be getting some induction therapy as an outpatient potentially, and that is, it's good, but you need to have close follow-up. You need to have management. If things arise, there need to be ways to deal with that. And usually right now, a lot of those are set up in the hospital system. So that needs to be addressed in an outpatient setting. And that's a big shift potentially. So those are, both things that I think are really relevant. And then the last part also is that flucytosine is used in this regimen. And flucytosine really does have issues with accessibility worldwide. And so that needs to change. The WHO is actively working with multiple partners about increasing availability of that. But in terms of practically applying this to many, many settings, deoxycholate, liposomal amphotericin B, and flucytosine might just impractical compared to amphotericin B deoxycholate and fluconazole, for example, where they use it commonly. So there are a lot of operational changes that might need to occur and also cost issues. But the idea is that this potentially is such a benefit that maybe it's worth switching over. So I want to leave a little bit of time because I do want to have a little open this up for discussion and questions, of course, and so forth. As I mentioned, flucytosine is not always available internationally. But one thing I thought was interesting is sort of how do I feel about this regimen? So this information is very new, and the conclusions that the authors pose is that in a low and middle income settings with a high burden of disease, they feel the generalizability of this data is quite good, and I tend to agree. So definitely, I think there's an argument to be shifting to this new regimen internationally, in those settings. But what do we feel about this regimen in places like here in San Diego? And I have my own opinions, but I do, if people are interested in unmuting themselves and talking, if anyone who's maybe read this paper or is thinking about this regimen, who would feel comfortable with adopting this regimen, under what circumstances, or would you want to wait for something else before considering this regimen? So I do want to take a pause here and just open it up to the audience. I don't know, again, I don't want to, I know it's Friday morning, so I don't want to push to people, but I don't know if anyone has any opinions they'd like to share or impressions.
Rehan, very nice talk. Can I go?
Absolutely.
Yeah. So yeah, I mean, that's an excellent overview, and I love this study and was sort of waiting for something to come out like this. I think you hit on some of the most important points, which are this sort of is great in terms of resources and can really shift the treatment of cryptococcal meningitis into sort of a more ambulatory setting, when appropriate. And I think that's very, very important for resource limited settings. Just one note also, they were using liposomal amphotericin, high dose ambisome, I guess is what, how we know it here. And so, you get away with the sort of high dose single infusion, whatever, because of the CNS lipophilic accumulation, et cetera, sort of a long half-life. So I guess that's why it's worked. As far as it's a good question, a provocative one, I think, about whether we can and would use it here. You notice they're comparing it to their sort of ACTA trial regimen, right? Which, is again, sort of I wouldn't say compromise. It's a very good, regimen for resource limited settings. But, I still think there's probably no comparison to, sort of what we do with a sort of longer induction, with frequent monitoring, et cetera, et cetera. So, I think it's good as sort of in that setting. It's good for us to know that, high doses can be tolerated, in this manner. For whatever reason, we have patients who like to direct their own discharge, let's say sometimes, or leave against medical advice. Not something we want to do, but well, we know we can, give a high dose if needed. So, that's one thing that one use that I think we might have applicability.
Robert, I think those are great points. Because I think, and Rehan, I think we'd love to hear your opinion. I think a lot of people read this and said, yes, can we do this in the United States? How will this help us? What? And I'm sure a lot of people are thinking about it. That's great that it was done in some of these, low and middle income countries. But of course, how does this relate to our practice? And I think, Robert makes a very good point that it's the comparator for this is a regimen that we don't use in the United States and other high income countries. So, what do you think we need to, what would be the next steps if this was something that we did want to do in the United States and other countries similar to ours?
Yeah, so my thoughts on reading this were, well, this is a great option, and the way I agree with you entirely that the comparator for this study is not directly comparable to what we do here. And with ambisome, episomal amphotericin B, just thinking of things like Mucor or some of these other things, we do super high doses, of ambisome, and people tolerate well. So I do think these higher doses are tolerable. I mean, I shouldn't say everyone tolerates it. Well, that's a gross overstatement, but it's more tolerable than the oxycodone, certainly. And so I think these are definitely options but I think what would need to be done, and maybe this is not, I mean, I'd have to think about it more as well, but my sense is that it would be important to have a direct comparison between the 2-week liposomal amphotericin B and flucytosine induction and this regimen, because it's too many steps of removal from non-inferiority to non-inferiority to non-inferiority for me to feel very comfortable at this point doing this. With that said, as you mentioned, Dr. Dice, there are patient-centered discharges that occur, patient-directed discharges, I should say, and there are people who do not want to stay in the hospital or just won't stay in the hospital past a certain point. And in those situations, this is the I think the support for saying, hey, we can stop amphotericin B, especially if we aren't able to monitor them, if we aren't able to deliver it. And we can consider for those patients with the understanding that there's no direct data comparison, but maybe that high dose oral regimen is the best way to go about managing them as an outpatient. And there's now some data to support that regimen, even though it's not ideal, it's better than what we otherwise might consider. So we have some guidance in that scenario. So I would use this. I would definitely wait till more information comes out, especially in sort of for our settings. But I would use this as a sort of a alternative plan when our traditional therapies are not, for practical reasons or otherwise, easily doable. And so I feel somewhat comfortable in moving in this direction for those patients right now. And I think it would be justified if someone were to review it afterwards and say, was this the right choice? Certainly patient-oriented.
I think Chris Matthews makes a very good point. Darcy also sort of gave an idea about what kind of study you could do in the United States. He said that I think 24% mortality at 10 days is considerably above what we would expect here with optimal pressure management. So I think that's a really important thing to remember. And I don't think the framing, and then Shannon also makes the point that the flucytosine dosing regimen would be challenging potentially for someone to leave with. I think anything 4 times a day is just begging for failure. So, I think sometimes when we go, I think a lot of the questions sometimes to us as the ID HIV consultant is, if this patient has a PDD, patient-directed discharge, what can we do? And I don't think we should be leading when we see patients with, well, there's this alternative we could do, if you needed to leave, because I think that then potentially gives a window. Right. And I don't think we wanted, at least that's my take on this. This would really be sort of your last resort until we have more information here. And I think those 2 considerations that Dr. Matthews and Dr. Balcombe just wrote are really important. I don't know if others have thoughts.
I think I was being more theoretical, but
no, we all I know what you're saying.
No, exactly. I am surprised. Just one other issue, Rehan. At the sort of, like you said, it's almost miraculous that there was nobody lost to follow-up or withdrawing or whatever from the study. And I don't know if you have any insight or know how that might have occurred, just because it seems so very different than a real world setting, is another sort of fact to point out in in this sort of, interpretation of a clinical trial. I also worry in these studies, about the sort of need for lumbar punctures. I know they did them, and, it seems like, again, there was no difference, but, I mean, part of the benefit of the longer regimens and sort of the frequent monitoring that we do is for intracranial pressure, et cetera. So, yeah.
No, I mean, I think, I don't know, I don't believe, and I have to look through the supplements to see if I can find it, but I don't believe there was a great, they said that they did these things like lumbar puncture, et cetera, as a concurrently with the treatment, but I don't know if there's a breakdown in terms of how many they did on average per country, for example, per cohort or subgroup. So I'd have to see if it's in the supplement. I didn't see it when I first looked through it. Presumably it was being done. And I think I definitely, I agree that the follow-up, it's more, the follow-up in general in these studies tends to be higher than I think we see it elsewhere, because a lot of these patients do end up being tied into pretty robust, public health ministry systems and so forth. And it's part of the time that they're in this being cared for, they're in the hospital, and then in follow-up, there are a lot of different mechanisms to call patients to try to do, community outreach. And so I think those mechanisms are stronger sometimes than we expect, but it's still very unusual to have nobody lost to follow. So this is still an outlier in that sense. And I think that is, I don't have a great explanation for exactly why it is. But I agree, I think with what everyone's saying, I want to clarify that, yeah, I would consider this more as a backup option for a unique situation. And I certainly wouldn't pose it as an option to the primary teams personally, or to the patient ahead of time, because that makes it seem like it's a viable alternative that has just, that has a basis for making that recommendation. No, I would just keep this more as evidence that there is an alternative if something were to go, in a direction where our standard of care is not possible. That's my take at least. But I wouldn't move anything. But internationally, I mean, in settings where this is applicable, I think we're going to see probably some changes to the guidelines as a result of this, which I think, again, given the scope of this issue, worldwide, that will the scope of impact to the patient, especially in terms of adverse events, is going to be, I think, significant. Assuming the same data holds up. Again, this is a single study at this point. And then the last thing I also have heard, and again, this is sort of just an extra thing, I think there's a lot of sometimes criticism of open label studies and these things, but we're talking about the outcome is mortality. We're talking about really, so I think personally, I don't feel that strongly about those criticisms. I don't know if that's, and it's really hard to, how are you going to blind someone to these types of injections? It's just not practical. So I think overall this study was done, very well, excellently, and I think that that's why I think we may see some changes to the guidelines eventually from this, because it does seem so. I can't imagine how they would do it differently at this point, at least.
Jill, what's the spoiler that you're referring to?
Oh, I thought Darcy gave a really good idea for how you could study this in the United States and sort of stratify people by mild versus moderate to severe disease, because maybe you can make the argument that someone with, mild disease, who's asymptomatic, but they're, with their opening pressure is quite low, and they're, that maybe this person does get just one shot and then the rest of the regimen, instead of them, keeping them hospitalized for two weeks, right? 2 weeks. So I like that concept. That was the spoiler, and maybe it wasn't a great spoiler. So I should give credit to Darcy. It was a good one.
And I think ethically, it also is it makes the most sense to start with that patient population.
Right. All right. So you'll be starting to lead that clinical trial. You'll start thinking about that.
Yeah. Give me a date.
Good. Yeah. Okay. And then what did Katie say here? This might, I don't know if you can read it if you'd like.
Katie says it's tough because this seems best for the rare patient who can't stand or be financially ruined to stay in the hospital. There's excellent follow-up, including repeat LPs and outpatient setting med adherence. There also obviously have to be an in-depth risk-benefit talk, including mortality rate with patients since it's not standard of care. Yeah, definitely, yeah. And the outpatient LP part is the part that scares me the most. So I probably wouldn't discharge a patient in our situation setting without, unless they have a very clear plan for that, I would just keep someone in-house until that situation improves.
They'd have to follow up with Tom Martin, at least, or Will Toproff in our clinic.
Oh, yeah.
But it's not like they're getting them so fast in the hospital either. So I'm not sure if it matters. Anyway.
That's an ongoing challenge.
Oh, and then, oh, there's a lot coming through now. I realize it's 9 o'clock, but Shannon wrote, FYI, flucytosine pretty much always needs a prior auth with insurance due to cost, and pharmacies don't keep large quantities stocked since less commonly used. Many patients, yes, agree, Shannon. Many patients in low and middle income countries are far from settings where repeated LP and shunting are possible. Treating toxicity management is difficult or impossible. So an all regimen is still needed, even if not as good as amphotericin-based regimens. I think we totally agree for that for those countries. I think we quickly shifted to what we would do here, but I think this is an incredible study that will be, dare I say, game changing for these countries. Anyway, it's 9:01 now. I didn't mean to have the final thought there. Pass it back to you, Rehan.
Well, I just want to say thank you. It's very nice to be able to present to this group, and I just want to, hopefully anyone who hasn't, again, who I haven't met in person, I have a chance to say hi to, and hopefully we switch to in person, and so I can pop by and introduce myself.
That's actually a great segue, because our first in-person or hybrid version of High Rounds is going to be April 29th. Thanks to Robert Dice for getting us some really cool speakers from, I'm forgetting the hospital in Tijuana, Robert.
It's Las Memorias, the TB, HIV, and substance use treatment shelter, essentially, with Daniel Park from San Isidro Health and Roman, I forget his last name, who works at Las Memorias. So yeah.
So we'll talk a little bit more about what that's, maybe we'll save a little time next time, Marvin, to make sure people know what they need to do for that. We're going to try to do an RSVP system because we can only have a certain number of people in the room. So we just want to have a sense of who wants to come. And if for some reason you arrive and the room is full, you just would have to either go to your car or go to your office. But we're really hoping that, we can start to do this again, because it'll be nice to see people. All right. Anyway, 9:03. Rehan, thank you so much. This really was fantastic. See everyone next week.
Bye.
Bye.